Okay, assalamu alaikum everyone. My name is Momo Arai. I'm an intern, and today I'll be talking to you more about ophthalmology and one of the lectures on anti-glaucoma drugs. Um, yeah, which is an eye condition that we'll talk about more in this lecture. So to begin with, let's start because we have 6 lectures. Um, so first, let's start with the vision and the visual impairment. Now, these lectures are all by Dr. Salwa, so I'll try to make all of them easier or how to memorize at least like the important ones for the exam. Okay, so first to start with the visual pathway. Now you'll take more about this in anatomy. The only thing that I'll touch upon here is the pathway for vision. So firstly, it will go through all these layers of, you see here, cornea, anterior chamber that you must have taken in anatomy, iris, lens, pupil, all of that, to go to the back of the eye to our retina. So retina, in the retina layer, the center of that is something called the macula. Okay, so that is the center of our vision. And then what I mean by center of vision is that it has the um, cells that are responsible for vision. So things like the rods and the cones, which are also called photoreceptors. Okay. Now, and then yeah, ignore. You don't have to remember know all of that. She will never ask from here. At least from these lectures. Just know that rods and cones are in the macula. That is the center of vision. And then after that, after it hits that layer, the optic nerve or the nerve fibers go from here to the optic nerve. The optic nerve carries it all the way to the occipital lobe, which is the vision lobe for vision, right? So it goes through there. Optic chiasm is the crisscrossing of those optic nerves from right and left. Okay, and then it goes to the thalamus. In the thalamus, there is something called lateral geniculate nucleus, and then it goes to the occipital lobe. Now, this is important because I want to talk about abnormalities in if anything gets cut off in this tract. Okay, so now, like I said, macula is the center of our vision. It's in the retina. It's so when you see it in an exam, like the not exam, the eye exam or the retinal exam, you'll see it's a darker spot. If it's very close to the actual optic disc that you see when you do it with the ophthalmoscope, you'll see the bright spot, right? That's the optic disc. Okay, and then a darker spot next to it is that's actually the center of the vision, the macula. In the center of that is something called fovea. Okay, the fovea is like a dip in the macula. Oops, sorry. Yeah, in the macula, it only has cones, so not the rods. So that's why it's less than the surrounding area. Cones are for color. Remember C and C. Rods are for night vision. Okay, so this is your central vision, center of the vision and everything. Just remember that. Now, the reason why it's darker is because it's avascular, so it doesn't have blood supply. And yeah, I talked about the fovea in the middle. Um, and that's mainly it for now. Remember that the retina itself, it has 11 layers. She emphasizes you to know the 11 layers, but I've never seen a question asked about this. But I'll try to make it easier for you. So remember that light hits here. It goes to the back of, it touches these cells, and then these cells transmit to the nerve, right? So that's how the layers are done. So the bottom is the retinal pigment layer. It's the actual pigment, right? So just remember that's the first layer. Um, then you have now how I like to remember this is you have outer and inner layers, like it's like a sandwich, all of them together, okay? So first you have outer segment, inner segment. That's it, outer, inner. Then you have outer limiting membrane. Okay, so you must have an inner, right? That's actually the last layer, inner limiting membrane. Then you have, see here, outer, 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 and then here is inner, inner, inner. Okay, just bear with me for a while, and it will make sense hopefully. So retinal pigment, then outer, inner segments, that's separate. Then you have outer limiting layer, outer receptor layer, outer plexiform layer. Then you go to inner. inner nuclear layer, which is this one. Okay, it's like a sandwich of all of them. Then you move again, it's like a pattern, I guess. And then the outer plexiform, so now it's inner plexiform. And then, like I said, the last layer is the inner limiting membrane. So limits, two limits. Okay, so between that, there must be nerve fiber and ganglion cell. So ganglion is 9, 10 is nerve fiber. Just remember, nerve, the actual nerve fiber is number 10. Okay, it's important, it's number 10. That's actually so these are the layers. They travel to the they go from there and then they converge to form the optic nerve. That's the actual center of the optic disc. It's bright, but it's just the nerve itself, okay? And it's vascular, that's why it's bright. Okay, now remember the visual tract. Like I said, if anything happens anywhere, you will have loss of vision. So this is the left eye, okay? And everything in the eye is like opposite, contralateral. So even the vision. So this side of the vision, so my left, right? This side, my left side goes to the right of my eye, and then this just goes like one of the fibers goes to this side and the right side, the other goes to the left. Again, don't try to overcomplicate it. Just remember that everything is opposite. So let's take the left eye, okay? Um, and let's say there is a lesion here on the optic nerve. The optic nerve is a conversion of both of these nerves, right? From either from the right or the left side of your eye. So if that is cut, then the whole vision is lost. So that's called monocular vision loss. Okay. If the lesion is, let's say, optic chiasm, which is what you must have taken in endo and everything, basically it's crossing off the nerves here, okay? Here it goes to the that side, to the right side, and then from the right eye, obviously, it will go to the left side. So that crisscross, okay, it affects which side of the vision? The opposite side. So this blue is here, right? Going to the right side, and then but it actually serves for the vision on your lateral side of the left eye and then the lateral side of the right eye. So that's why when there's a lesion here on the crisscross, you get vision loss on the outer sides of your eye. So people will have trouble driving or anything that is not on their straight path, they will have trouble seeing that. Okay, so that is called bitemporal hemianopia. That happens with like tumors in the pituitary gland and so on. Okay, which sits there. Now let's say that it's in the optic tract. So this was nerve. Now both of these nerves come together, they form optic tract. Optic tract on your left side, if it's cut off, okay, so on your left side, then it's gonna affect the right side of both your eyes because now it's a conversion of both, right? So the right side of both is affected. Again, just remember contralateral. So left optic tract, right side of both vision. Okay. What about, let's say, so let's say there is now it branches off into two nerves. One goes up, one goes down. The up one goes through parietal upper radiation. The other one is lower temporal. So the temporal lobe sits lower, right? So it's lower. But what does it affect? It affects the opposite vision. So the upper parietal one will have loss in vision, or it supplies the vision in, wait, sorry. Yeah, upper temporal, upper parietal, sorry, will have will it serves for the vision. So if there is a block in this one, you will have block in the lower side of the right right eye. I know it's very like confusing, but yeah, it's it's just remember left and right, okay? So if the lesion is in the left side of the parietal upper, then you will have vision loss in the right side of the lower quadrant, okay? Like that. So contralateral vision loss, because this blue thing comes from that side. remember that. Now, what about this one? So if the lesion is in the lower temporal side, lower temporal, so the vision loss is in the upper quadrant of the contralateral. So left side, that's the right, okay? And so on. And then if the lesion is at the end where the two nerves are, it's where it's in the near the occipital lobe, you will have macular sparing because, so that macula, the center of vision, is spared because the macula is supplied by both sides. So both sides of the occipital should supply the center, okay? So if one side is blocked, then it doesn't affect that. So it only affects half of the vision, sparing the center, okay? Because the other side is still sparing, supplying the center vision. I hope that made sense. So everything is contralateral, 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 okay? The only thing that is ipsilateral is at the beginning before the crisscrossing happens. Okay. Now this is another diagram showing you like left and right both sides and the crisscrossing, but it's basically the same thing. You can use what I just said here, okay? Now, visual impairment can happen very suddenly, so acute, or chronic over a long period of time. The important thing is you take a good history, ask when the vision was last tested, and all these different kind of tests that you would do in an eye exam. Acute can be opaque, something blocking the cornea, something blocking your iris, pupil, everything that can happen suddenly is acute. And then but it's important to differentiate, to do these tests to differentiate from functional disorders. Functional disorders means that there is no actual cause. The person might be lying, it might be like a psychiatric disorder. How do you tell that apart is by doing these tests. Functional, the one with no cause, will not have an impairment in the sense the do you remember the autonomic senses? So pupillary defect, afferent pupillary defect means like when you shine a light in the eye, it's supposed to constrict on its own, right? So that still happens in functional, which means that there is no problem. In the others, you as we'll see, mostly something in the exam is affected, whereas in functional, there is no defect. Okay, that is the main thing. So what do you see in this exam? Just to make you think. So obviously we've all used it before in pro. This one, it's called an ophthalmoscope. How do we know if it's direct or indirect? So the one that we do it is always direct, okay? The indirect one is something that we do it closer to our eye and then we just see. It's a different technique, but basically the one that we do is direct. The indirect one is closer to your eye and you just look at the patient from far away. Slit lamp is the thing, so it's like a lamp and then you shine it through the eye and you see it. Retinoscope is something else. It's more detailed. It looks at the retina in much more detail, okay? But for you to know, because this came in an exam before, so. Okay, so let's say, so acute vision loss can be a lot of things. First, one of the main things is opacity, something blocking your vision can be due to corneal edema. So that can be due to like that. Okay, so it's increased white ground glass opacity can cover the eye. That can be caused by edema, which is caused by a lot of things like increased pressure in the eye, ulcer, or glaucoma, which we'll talk about in a bit. So opacities can be edema or blood that's covering the front of your eye. So blood in the anterior chamber is called hyphema, or blood in the posterior side in the vitreous humor. So vitreous humor is the fluid in the back of your eye, and it's if blood fills it, then you will have opacity again. Okay, and then you will not be able to see because again it's blocking that back and the front and then from the front of the eye itself. So this one is in the anterior chamber, it's painful, and then this can have be variable, but if it's in the back it's painless. So imagine it's like a silent thing in the back, it's painless, but the person will lose vision immediately, whereas in the front you can see it looks painful, so That's, yeah, you can remember it as that. So blood in anterior chamber versus virtuous humor. The important association for this is diabetes. It can be caused by a number of other things, hemorrhage, trauma, surgery, blood disorder, but the main thing she focuses on is diabetes. So diabetes is an underlying disorder. It's systemic and it can affect the eye. So just remember that that can cause bleeding that can happen because of uncontrolled diabetes. Okay. The other thing, so other than opacities, you can lose vision in something called acute glaucoma. Glaucoma is, so like anything, we have pressure in our eye. We have blood pressure, we have CNS pressure, right? In the eye, we have intraocular pressure or IOP, okay? Inside the eye pressure. Um, if that increases suddenly, that is called glaucoma. That's the definition. So acute glaucoma is increased intraocular pressure. Can be due to a number of reasons, can be age, can be something trauma, and so on. Main thing is that because of that increased pressure, it compresses on that optic nerve we saw before, the bright light. Okay, it compresses and it causes the fluid to build up kind of around it, and that's why it appears very, very large compared to this one. I know you would think that it would compress because of the fluid, but what I mean by this is that it's large compared to normal. Large, so let me explain. So this one is the optic cup, and then this is the optic disc. It should be smaller compared to that, but because of that increased pressure, it just pushes it all together, closer and closer. So it's larger, it seems larger, bigger optic cup compared to that ratio that was here before. Okay, I hope that made sense. So it's because it's pushing from everywhere, it just compresses and makes that ratio bigger. So that is what we call optic cup or optic cupping. Okay, that happens in glaucoma, and it is an emergency, and it's very, very painful, and it causes very red eye and so on. And it makes the eye stuck in some way. Okay, we'll see later what I mean. So emergency, and then there is another thing that can cause acute vision loss, which is retinal detachment. The retina can suddenly detach from we saw the layers of the eye, right? Retina is the last layer. It can suddenly detach from the eye, and it can happen painlessly. And the person will have other symptoms like flashing of lights or blind covering of the eye. And the main important thing is that there is an afferent pupillary defect. Because the retina is now detached, the when you shine the light, it will not work anymore, and that is what the defect is very important in retinal detachment, in painless loss of acute vision loss. This is also an emergency, and this is an emergency. Okay. Now, retinal detachment can happen, can be due to a lot of causes as well. It's not that important for the sake of this lecture. Just remember the symptoms and the defect. That is the most important thing in bold. Okay. Other two causes can be occlusion. So blocking veins, so central retinal venous occlusion, or the artery, central retinal arterial occlusion. So if the vein is blocked, you will have so both of them can cause acute vision loss. If the vein is blocked, you will have this kind of picture. It's not specific, right? It's to like the to like the artery, it's more diffuse, you can say, and it will cause something called blood and thunder appearance. So it looks like thunder, it looks like bloody, like a mess everywhere, right? So that is the venous occlusion that can happen. Can be severe loss, dilated, tortuous veins. Again, all of these edema, hemorrhage, engorgement. You don't need to remember all of this specifically, but just remember the appearance. Blood and thunder, if you see that with venous occlusion, that is central retinal venous occlusion. And for this, the management is no acute management, even though it looks bad. It's not as like it's not as emergent as it looks, okay? Whereas this one is the opposite. So if the artery is occluded, just remember artery is more important in any case. So it can be blocked by atherosclerosis, plaques that can travel to the artery and block it, just like in heart attack. So remember, arteries are very much more important. What is important is that because it's blocked, one central artery is blocked, we have a cherry, it looks red here. It's blocked. It's very easy to remember. Cherry red spot because of artery occlusion, and that one is emergency. Okay, this is more emergency than that one, even though this looks milder than that. Now it can cause again embolus, ischemia. You will see white around it because it's ischemic. It's blocking that arterial supply, whereas here it's more of bleeding because again, blood and thunder appearance, and it's vein, not an important artery. It just blocks. So imagine a vein is blocked. It just blocks the drainage, right? Because that's what veins do. But that's what veins do. So if the draining is blocked, then it will just accumulate and cause that bloody spots. Okay. Now, again, I hope that made sense. That one is cherry red. This is blood and thunder for vein. If you have inflammation of the nerve itself, so you will see here, it looks different than any of the other pictures. It looks inflamed and it looks not really ischemia, and then it's like in the middle, right? So it's like it's only around the nerve too, if you notice. So that is optic neuritis or inflammation of the optic nerve. Again, remember the bright light. What do we have here? If you have damage in the nerve, then you have damage in the pupillary defect, the shining bright light thing. You will have a swollen optic disc, and it usually recovers, but it can cause permanent vision loss if it happens a lot of times. Now that can happen acutely, episodically, and one of the association is multiple sclerosis, so because that can cause inflammation of nerves, right? It's an autoimmune. Now, so remember afferent pupillary defect we talked about in optic neuritis here, optic nerve defect itself, or the damage in the retina, so retinal detachment. Both of these are related because both of them affect the nerves, okay? What about cortical blindness? So cortical, from the name, it's blindness, so vision loss because of damage in the cortex, in the occipital lobe, that it can cause two, like vision loss, bilateral damage in right and left eye. But the important thing here is that it has normal pupillary reflex and fundus. Why is that? So because the damage is in the cortex and not the retina itself, not the nerves. So even if you shine a light, it's automatic reflex, right? So it will, like, the person will still have that reflex, even though they're blind, if that makes sense. So they are blind from the back, but their automatic sympathetic, parasympathetic will still work because they go through the brainstem, if you remember, not the lobe itself. The lobe is just for vision, and if that's lost, then only the vision is lost. Okay. Now you can also have chronic vision loss. So if she asks you what is the most leading cause of blindness, the first leading cause of blindness, especially in case Saudi, is diabetic retinopathy. Why? Because diabetes is very prevalent and it is the leading cause of blindness. Second leading cause of blindness is glaucoma. Okay. Um, in chronic glaucoma takes place over a long period of time, unlike acute glaucoma, which will be explained later. Now, the important thing again, try to catch it early, measure it with the tonometer. So you can measure the pressure with something called tonometer and then evaluate the eye itself, the macula lens, from time to time, especially in older age. Chronic usually happens over a long period of time. So with age is a risk factor for all of them actually. Okay. So what's the first one? We said chronic vision loss. I'll talk about glaucoma later, so don't worry. We'll move to cataracts. Cataracts is opaque, like opacity that we saw before. It's white, but in the lens only. So you will see that it's only the lens that's white, right? Do you see that here? here. All of these are cataracts. The opacity that we saw before was the whole entire eye, like that. So that is not a cataract, not clearly. If it's only the lens, that is a cataract, okay? Now, what is the cause? It's age related. Again, no need to remember all this. Just remember age related and things like environmental. Steroids is one. Sometimes steroid can cause cataract or dry eyes. If someone is using them for a long period of time, you can imagine it causes stiffness of the lens. Okay. And then there are other causes like infection in cataracts in children, like rubella, toxoplasmosis. I'll come to that in a bit too. The again gradual symptoms, why is that? Because the proteins or the fibers in the lens start to become disorganized over time with age mainly, and that can cause abnormal reflection of the eye, like blocking the light path. So it can cause symptoms like contrast sensitivity, which means like in low light they cannot see much in darkness, and they will have also in bright light they will have another problem, which is glaring. So in driving at night, for example, they will have trouble seeing because of the bright flashes of light. Okay, because again, it's cataract is not normal. It's blocking that sort of light. The treatment for cataracts is very easy. If you see that white lens, you just remove that lens and then do a lens implant to fix that. Okay. What about chronic vision loss affecting the macula? From the name, we have macular degeneration, or we have, I'll come to it, diabetic retinopathy, which is the number one cause, right? So macular degeneration, if you have degenerating macula, the first thing that we saw here, remember that? The darkness there. And then if that is damaged like that, degenerated, this is the normal, this is degenerated, you will have loss of which vision? Central. Does that make sense? Because macula, we said, is the center of vision. So obviously, if that is ruined or damaged, then you will have loss in the center of your vision. It's the leading cause of irreversible central vision loss. So, number one cause of central vision loss, central is over 60 years, is this. Okay, macular degeneration. Again, age is one thing among others. What do you see in the retina? So you will have macula. Obviously, this is MRI of the retina. You before that in the fundoscopy, you can see more specific changes called drusen spots. So drusen spots are yellowish spots over the macula. It can be around the macula. It can cause optic nerve damage, everything. But drusen spots are small yellow colloid substances that are deposited in this membrane. Okay, you don't need to know the name, I think, but it's called Bruch's membrane. That happens because the macula is degenerated, it causes damage, and all these yellow spots are specific to macular degeneration. Now, what is the other macula problem is diabetes. Diabetic, from the name retinopathy, it affects the retina, especially the macula. Now these are not drusen spots. These are more like you have to look at the overall picture. So drusen spots are very like it reminds me of like fat molecules. That's why I said colloid and so on. But here they're more like dispersed and not as thick, right? And also you have to look at the other changes in the eye, like these hemorrhages that you see here, blood. And then here there's arteries forming. So that is a very classical sign of diabetic retinopathy. Now, why is that? Diabetes affects, it's a sugar imbalance, right? It affects the arteries, it causes them to be weaker. Again, because of that uncontrolled sugar, it causes them to be like thickened basement membrane, capillary damage. It causes them to leak, and then that causes a lot of things. So the main two things is microvascular invasion and then microvascular leak. That's all because the vessels are weak and leaky. And then the blood is not able to go through the damaged vessels, right? So that causes ischemia around the area. It causes fluid to leak out. That's another thing. And it causes shunting. So because the eyes are not able to use this path, they create their own shunts or capillaries to bypass the damaged vessels. So that is what we call microvascular invasion, formation of new arteries that take place to bypass the ischemic old weak arteries. So that causes ischemia, AV shunt, and that term, the shunt or the formation of new arteries, is called neovascularization. Then the leak is other thing. The leak causes things like edema, exudates all over the eye. And that is another important thing in diabetes. Okay. Now, all of these are pictures from diabetes. Just remember diabetic retinopathy. Remember, there are two important types. There's four, but two are important: non-proliferative and proliferative. The edema and the end stage are other stages, it's okay. But basically, remember what I said? Neovascularization is the formation of new arteries and vessels. That is, by definition, proliferative type. If the diabetic retinopathy is like severe in a way that there are not even new vessels forming to um, make up for the ischemia, we call this non-proliferative type. So no vessels, okay, versus proliferative. In the non-proliferative type, you will have the leaks and you will have exudates more, okay? In the proliferative type, you will have that vessels, neovascularization. Remember the difference between the two because it will get asked a lot, okay? Now, in these pictures that she put, um, what do you see here? You see vessels forming, right? See here, these are abnormal vessels. They should not be too many vessels like that in the eye. If these vessels are near the optic disc, the bright white light, we call this neovascularization of the disc, NVD. If they are away from that disc, we call this neovascularization elsewhere, E. Okay, and then you have other things like hemorrhages everywhere. So it can cause like retinal hemorrhage here, retinal hemorrhage here. Okay, or we can call it pre-retinal hemorrhage sometimes. Main thing is neovascularization is sign of proliferative, and it can have also hemorrhages as well, but that's not specific. What is the treatment? You can do laser therapy. So it's light amplification stimulated. It's you don't need to know all of that. But basically laser therapy will kind of seal. So it's as you can see here, light amplification radiation therapy. The radiation will cause the leaks to stop, and it will shrink the growth of new blood vessels, which is why we use it in diabetic retinopathy, because it is again the number one cause in blindness. Diabetic retinopathy is a systemic disease. It's another lecture, but I brought it here to bring it all together. And you can have other things with diabetes. So you have proliferative, we discussed before, right? Proliferative means new vascularization everywhere elsewhere or on the disc of normal vessels, or non-proliferative, which will have no new vessels, but you will have these yellow, like not discrete, they're like all over the eye, kind of like that, like that, like that. These are exudates, okay? They're not colloids, they're everywhere in the eye. So we have that is called exudates in non-proliferative. Another thing in non-proliferative is edema, okay? Macular edema. So the edema, leaks, exudates still happen without the vessels. Then you can have other findings like the one I said. So because these abnormal blood vessels are there, sometimes they can burst because they are again weak new vessels. They can burst and cause hemorrhage to come in the virtuous space or pre-retinal space. That is one cause of virtuous hemorrhage or virtual. Remember here we said diabetes is important. So virtuous hemorrhage. One of the causes is diabetes because of the formation of new vessels that can leak everywhere. Another thing is cataract. Remember how I said cataract is lens opacification? It can come in diabetes as well. Okay? Now, that is it for the first lecture. So remember, acute, chronic. Chronic can be diabetes, that's the most important, or macular degeneration, or cataract, or chronic glaucoma. Acute can be a lot of other things. And then we will now talk about red eye. Red eye, from the name, eye that is red, because of the vessels that are in the sclera. So it can be from a lot of things. So it can be from the cornea, conjunctiva, sclera, um, what else? Iris. Anything in the eye can cause red eye. Any of the structures, I mean. And it's important to know whether it's painful or painless, and if it's serious or not serious. Emergency red eye or acute glaucoma. Remember, we talked about that before. It's emergency. And then anterior uveitis. So uveitis, anteriors, uveitis is important, and scleritis, which I'll talk about in a bit. So scleritis is the inflammation of the sclera, which is the white part of your eye here. It's not supposed to be red. Um, but if it is, then it's an emergency. Okay. Now, uveitis is the middle layer of the eye. So if that is red as well, it will have a different presentation, but basically just know these three for emergency. Now, again, the red eye can be from a lot of different layers. We'll first talk about conjunctiva. Conjunctiva is, so you see here how, like, so this is the eyelid, right? And that there's like an inner fold inside the eyelid. That is your conjunctiva, okay? If it comes in front of the iris and the pupil, that's called now the cornea, which is a thick layer. Okay, but on the side, when it's like dipping like that, it's the conjunctiva. You have three parts in conjunctiva. You have the fornix, which is the like fornix, like the curve at the end. It's like a cave. And then you have a dilated part, the bulbar, and then you have the palpebra conjunctiva, which is the one attached on with the eyelid, okay, on that side. I hope this is a clear picture. And then here you can see even palpebra is with the eyelid. Fornix is the at the base here. It's not that clear here. Bulbar is the dilated part on the other side of the eye. It's not attached to the eyelid, okay? Now, conjunctivitis is when you have inflammation of the conjunctiva, basically. Stroma, this is again something from the lecture, but basically the stroma around the eye or the conjunctiva develops at 3 months of age. So babies can also have inflammation of the conjunctiva because this forms already. This is the layers of the eye from your anatomy. So cornea is front, sclera is the white part, lens is there, and conjunctiva is around the cornea. So with the three layers. Signs of conjunctivitis are things like discharge, edema, redness, obviously the red eye, lymph node is enlarged, or past exposure to cold or like flu virus. Okay, that can go to the eye and cause the pink eye. Conjunctivitis is the most common cause of pink, like red eye in the conjunctiva. You will see all of these findings, which I'll come to. And then there can also be benign growth in the conjunctiva itself, like these growth that are not really like inflammation, they're just growth. One of them is called pterygium, and then the other one is pineum. Oh, so wait, I'll switch this. Sorry, my bad. This one is the confined to conjunctiva, and this one is invading the cornea. And I'll get back to that in a bit. Again, conjunctivitis is the most common cause of red eye in the conjunctiva layer. It can be bacterial, viral, allergic. Bacterial, remember the bold words. Bacterial is very, very invasive. It will cause purulent, mucopurulent discharge, foreign body tearing, very, very painful red eye. It will sting, and the organisms, the most important one is strep. So Streptococcus epidermidis can cause it. Streptococcus strep can cause the red eye. It can be also staphylococcus, like Staph aureus, or Staph epidermidis. And yeah, that's And then this one is H. influenza, can also cause red eye. Remember the organisms that can cause it, they're bacterial. And then if it's a bacterial infection, obviously you would swab it for culture, like swab the discharge, and then you can treat with antibiotics because it's bacterial. Now, what about viral? The most common is adenovirus, and it's watery discharge. That's it. Watery discharge that can cause something called follicles. Because it's irritating the eye, it will cause like these small bumps in the eye. Again, other things are such as the nodes will be enlarged because again it's a viral illness. Think virally, so like think everything that's viral, so the lymph node, runny nose, redness of the eye, and so on. How do you treat viral infections is conservative, and you put cold compressors. Okay, if it's bacterial you put warm. Why is that? Because if you put warm compressors, it's gonna dilate the arteries, right? Because it's warm, and the arteries can supply the white blood cells necessary for to treat the to attack bacteria cells. In virus, not really. You don't really need white blood cells to attack it. So you, I mean, you do need, but you can just manage it with cold compressor or conservative management for viral. It's not as severe as bacterial. Same thing for allergic, you use cold compressors and so on. But the main thing in allergy is imagine someone is allergic to something, they are itching like at their eye. So this itchiness, this scratching can cause very thick bumps. So these are called papilla. So you see these thick that's because of repeated episodes and tearing and itching of the eye, which can cause papilla to form. Follicles are small, tiny bumps with virus. Allergic has bigger ones, and it's itching and bilateral. Okay, so there's history of asthma, family history of atopy and allergy. It's watery, mild red, and giant papilla can be formed. Now, treatment can be with cold compressors, antihistamines, again, conservative management. Think allergy, so you would give antihistamine, right? You don't really give topical steroids in this case in first line. You can if it's very severe, like in asthma, right? If it's severe exacerbation, you can give steroids. Now, what about the benign growth? Benign growth, there's pinguecula or pterygium. You'll see these growths in the conjunctiva. One of them is confined only in the conjunctiva, so we say it's pinned to the conjunctiva, pinguecula. And then the other one is invading the cornea. So cornea is the thick anterior part of the eye. It crosses something called the limbus, which is the border between conjunctiva and cornea here. Okay. And then once it crosses that layer, that is now called pterygium. Okay. So this is pinned, this is not. Now, this one crosses into the cornea. The causes of both of these can be very minimal, like it can be due to UV, dry eyes, wind, and dust. The treatment for them is both the same. Try to put sunglasses on when you go in the bright light, and lubrication of the eye is important to prevent these growths. These are benign. Um, Nothing much you can do. You can remove it for like cosmetic purposes, but some people will it will not affect their vision. Other benign conditions such as these. So if you see this, you would think that it's very emergency because of the bleeding in the eye, but actually it's not because remember if it's only in one portion of the eye like that, this is a bit severe. But if that happens maybe in one episode, maybe someone who woke up from sleep and they saw like redness, sometimes we see that. It's not as severe, but if they do see this, it's just underneath the conjunctiva, subconjunctival hemorrhage. So underneath the conjunctiva, just a blood vessel, maybe bled out for one time. It's very asymptomatic, and the causes can be like hypertension. That is the only thing. Someone should get it checked if they get it repeatedly, or bleeding disorders. It can resolve on its own though. Now, Valsalva, because of increased pressure in the abdominal pressure, it can cause bursting sometimes of the blood vessels. So that's what can cause that. Dry eye is another. benign condition. Again, we all have dry eyes because of the weather. It can cause burning, foreign body sensation. It can be bilateral. It can be due to weather. But someone who has dry eyes, um, not due to weather, can be because of systemic causes like immunosuppression. So someone who is taking steroids for a long time, someone who has vitamin A deficiency, someone who has a tear gland that is abnormal or infiltrated, someone who has collagen vascular disease, Sjogren disease, anything that can cause systemically can cause dry eyes. That is important to consider. Treatment for dry eye, but normally it's because of weather conditions. We can treat dry eye with lubricants, with the eye drops, okay? And this one will resolve on its own. What about foreign body in the eye? So we talked about conjunctivitis, right? Conjunctiva red eye. The foreign body can also cause eye to be red. Now, if you don't see a foreign body like clearly, turn the eyelid and sometimes you will see it there. So here, here. So if someone comes with red eye, it's important to inspect every aspect of the eye and remove that foreign body. Sometimes the foreign body can come on the cornea like that in workers and welders. You can treat with antibiotic if it's small, or you can just remove it. If it's let's say chemical injury, someone who like through like or by mistake spilled spilled like alkali, which is more dangerous than acid. The main thing is you have to irrigate it. You have to wash out that eye. The first thing that you do, if someone has history of chemical injury, you just get a water and just wash the eye. The faster the better. That will remove that chemical from the eye and stop it from being more damaged. The ocular trauma is the most like important thing, like emergency thing from all of this, is because you have to be aware of perforation of the eye, so it can cause softness of the iris, soft eye, protruding iris. You can see this is like abnormal. Irregular pupil is always bad. So that trauma is emergency. These are you can remove or you can treat with water. Okay. Now we talked about conjunctiva, we talked about foreign body that can affect the conjunctiva and the cornea. We'll talk about cornea. Cornea itself has 5 layers. It has epithelium, it has these layers you took in anatomy. Stroma is like a deep layer. If there is damage to the epithelial layer only, we will call this corneal abrasion. Corneal abrasion is very painful because there are nerves that are supplying this, and it will cause irritation of the eye and cause redness and swelling and pain. Now, that can be because of trauma, foreign body, only something that is blocking that epithelia or damaging it. And you can diagnose this by fluorescence. So, fluorescence is a dye that you put and you view it under blue light. uh, if you see green spots, that is the area of damage. So blue is normal. The green is like that means it's like scratches in the glass, if that makes sense. So the green is abrasion. So damage in the epithelial in this way. That again can be caused by foreign body and so on. If the whole thing is green, that means the whole cornea is like affected, right? So, but again, it's damage on the epithelial layer. If that abrasion is untreated, or let's say that it's a very deeper injury, then the stroma, the deeper layers, all of these layers are affected. That is now what we call ulcer. Corneal ulcer is deep. It's deeper than abrasion, and it is much more dangerous, and you want to treat that immediately. You want to rule other things out, such as so infective condition, inflammatory trauma, chemical condition, okay? Chemical injury. An important association with corneal ulcer is long-term contact lens wearing. So sometimes if someone is not taking care of their contact lenses, if it's there for a long time, not washing, not having good hygiene, it will cause irritation over a long period of time in the deep layers. So corneal ulcer. These are all pictures of corneal ulcer. The one thing you do is swab, take samples from the cornea, okay, inside. Cornea is the front layer, right, of the eye. So take cornea samples and treat with antimicrobials because ulcers are more prone to bacterial infection. So you want to treat that with antibiotics before it happens. Okay, you can see it's very red. Other infectious causes, which are viruses, can be due to herpes simplex virus or herpes zoster. Remember herpes simplex or zoster. Either way, they will appear with the same presentation on the fluorescence dye. So instead of this scratching, okay, you will see terminal bulbs like that. So they look like bulbs or at the end of bulbs, right? They look like small, tiny, like leaves or grass or whatever. These are in the fluorescence dye. If you see that, it can be these. It can be either herpes simplex or herpes zoster. How can you tell them apart? Herpes simplex is um, like not ulcers, but it's like vesicular rashes around the eye, or it can be any part of the eye is the most common, or oral ulcers, right? So if there's like this case, that is herpes simplex, it's mild discomfort, it can cause watery, blurred vision, the same thing, red eye. Dendritic ulcer is this thing. It's the same one here, so there's nothing different between these two. What is different is the distribution. So herpes zoster is reactivation of chickenpox, right? So varicella zoster or chickenpox virus. Reactivation means like in someone who is immunocompromised, someone who is sick, elderly, that has these, another name for it is shingles. The distribution is along the first division of trigeminal nerve. So trigeminal nerve, the first division, so forehead, eye, all of this is distribution. This is specific to herpes zoster. Herpes simplex is just around the eye, or it's not, there's no specific distribution that is limited to the trigeminal nerve, okay? Again, same symptoms. Another difference here is the maculovesicular rash that is on the first division respects midline, which means only one side of the eye is affected. Like you can tell that distribution is because of that nerve, because of how it respects that midline. See, it's very, very straight and very, very separate. Now, it can also cause or similar symptoms to anterior uveitis, which I mentioned is an emergency red eye before. The treatment for this is antivirals like acyclovir or debridement, so taking out those debridement of the face and the rashes, okay? They're very, very painful. Another name for this is herpes zoster ophthalmicus. Very debilitating pain. Now we talked about her this cornea, we talked about the infections that can cause it. Let's move on to sclera, the white part of the eye. The white part of the eye can have inflammation as well that can cause red eye. So that can be scleritis or episcleritis. Epi means above, slightly above the sclera, but still between the conjunctiva and the sclera. So above sclera, but below the conjunctiva. Now, so episcleritis is asymptomatic and milder. Scleritis, which is the actual sclera name, is more painful and tearing pain. That is more painful and more emergent than episcleritis. So you will see there are like few vessels on the sclera that is in episcleritis. It's very superficial. It's self-limiting. You can treat with topical antibiotics or topical treatment like lubricants. It is associated with a systemic disease like rheumatoid arthritis sometimes, and that's why it can cause inflammation of the sclera. Okay, that is an important association to know. Scleritis, which is more severe form, can cause blindness or necrosis, and you will see it looks very ugly, more ugly than the one, and it's very purplish, right? Now, because the sclera is white, okay, and there's inflammation, more inflammation than episcleritis, it will cause the other layers to kind of show through. So the white will be gone, and the choroid, which is below the sclera, which is violet in color, will start to show. That's why it's more severe and ugly looking. Okay, it looks bluish gray because the white color is very thin now because of the inflammation. Again, it is associated with systemic disease like rheumatoid arthritis, SLE, lupus, Wegener disease, polyarthritis nodosa, zoster, sarcoidosis. Anything inflammatory, vasculitis, systemic, can cause these two. Okay, nothing specific that you need to know. Just remember it can cause that. Now let's move on to eyelid. Now we talked about red eye, we talked about and the acute chronic vision loss. The eyelid has its own layers. You will see the eyelid, upper eyelid, lower eyelid, you have skin. The muscle of the eyelid is important to know. Remember that orbicularis oculi muscle is surrounding the eye and controlling our opening and closing. You have hair follicles, glands, and eyelashes. All of these are important because you can have, again, lot of disorders. Main first thing I'll talk about inflammation. Inflammation of eyelid is called blepharitis. Bleph is eyelid, itis is inflammation. It has an association with another infection of the bacteria, which is called styes. I'll come to that in a bit as well. Blepharitis is dysfunction of the small glands in the eyelid that we saw here. And one of the name is Meibomian gland. Anyway, the main thing is that there's inflammation of the eyelid, which will cause like these crusting lesions like that. Okay, dryness, pain, a little bit of pain. The important thing, how do you treat this is you clean the eye, lid hygiene with antibiotics, lubricants, and warm compressors. See, warm compressors again because inflammation, anything to do with bacterial infection, warm compress. Okay. Other benign conditions in the eyelid are these growths, like yellow growths. They look like fats, right? So they are painless growths of cholesterol, someone who has uncontrolled high cholesterol. This is called xanthelasma. And then here, if you look, what does this remind you of? This reminds you of someone who had like an allergic reaction, right? Because that is how we react to allergies or anaphylaxis, for example. So allergic eyelid swelling is painless, but it's just because of that exposure to allergies, exposure to again these like bees or weather. It can be a lot of things like pollen, dust can cause allergic reaction, which will cause pale, puffy eye. Again, allergy, main keyword is itchy, itchiness. Okay, it's painless, but it's just itchy. And that can cause a false drooping of the eyelid, which is called pseudoptosis. Okay. Now, lesions, so this is inflammation and benign things. If there are lesions in the eye, like eyelid, like this, like that, this, what's the difference between the two? These look more severe, more red, and the presentation will be acute. This is less red, but I know you can't tell, but it will be more over a chronic period of time and it's less painful than that one. Okay. This is called sty. So sty or hardelium, especially in children, is I'm pretty sure you might have seen them before in someone, but basically they're bacterial infection of the oil gland in the eye. So bacteria again has to do with pus and painful red swelling. What is the bacteria for sty? It's always staph. Staph aureus, staph abscess. Okay, staph aureus is the main thing. This is different from conjunctivitis, right? Because the bacteria for those were strep, staph, and H. influenza, but this one is mainly staph. Again, treatment, bacterial, you go for warm compressors plus antibiotics. If it's over a chronic period of time, it's affecting another gland, not the oil gland, called Meibomian cyst or Meibomian gland, which was the same thing in the blepharitis, but this one is over a chronic period of time and it's more localized lesion. This is chronic sterile blockage of the gland, which will cause backflow of the secretions and cause this red looking eyelid. And the thing for this, the treatment for this is routine referral. It's not emergency, but you can use antibiotics and do surgery to remove that over because it's chronic and it doesn't look good on the eye, right? So you can drain it or you can do surgery to remove it. This will go away with antibiotics and warm because it's acute bacterial. Okay, what about cancer? So other than lesions, you can have cancer of the eye. Basal cell carcinoma is the most common, 90 to 95%. It's mainly in the lower lid and the medial side, medial canthus, which is here, which is on the medial side. And it looks pinkish, pearly, like that, right? Now, I know it's very hard to differentiate, but just remember for the sake of this lecture, basal cell carcinoma is the most common. It is more common than squamous. So most likely whatever you see here is basal. Two types, there's nodular. Oh, sorry, this is nodular in histology, and then morphiform is like mixed morpheus appearance in histology. Squamous cell carcinoma is less common, very, very less common, even though the appearance, it can still be in the lower lid, it can be in the medial canthus, but it can also be, it's just less common than basal. Even though it's less common, it's more aggressive and it can cause invasion in the nerves, perineural invasion, and it can have pre-existing lesions. So it's more severe and it looks more whitish too and bigger than that one. This looks more pearly. That's how I like to know. It's like pearly and pink is basal, and more invasive, less common is squamous. If it's very, very red and you see here like glandular appearance, you'll see a lot of like secretions, like pinkish structures there. Again, it reminds you of adenocarcinoma, right? Adenocarcinoma always looks like this, but in the eye, it's even more like bad and very, very malignant, even if it's rare. This is called sebaceous adenocarcinoma, most commonly in the upper eyelid. So upper eyelid, multicentric and pagetoid spread means like it spreads all over like that, and all over like that in histology. Now, if she asks you what is the most common tumor or cancer in the upper eyelid, it's sebaceous adenocarcinoma. Okay? It's 2 times more common in the upper eyelid, whereas these are in the lower lid and the medial side. Okay? So, so that was cancer, that was lesions. We'll talk about malposition. So you see here, what are all of these in common? You see that the eyelid is not in place. If it's outward turning like that, if it's like going outward because of old age, droopiness, weakness of the muscle and stuff, this is called ectropion. So ectropion more common in lower lid. Ectropion is like outside. Entropion, which is inside. So you'll see like the eyelid is turned inside like that, right? You see it here. It's inwards, called entropion, again, more commonly in the lower lid. Symptom-wise, they can both be very dry eyes, painful. Epiphora means excessive tearing because it's like this one has dryness because the eyelid is not working. This is like touching the eye. So it's more painful and cause excessive tearing. Touching the cornea can also cause corneal opacity. Corneal opacity with the fluorescence test, you can see it because it's touching the eye, whereas here it's not touching, it's just dry eyes. And that can have decreased vision because it's touching the cornea. Okay, you don't want that. What is the treatment for these? This is like routine. You can do surgery to kind of fix that dry eye. And then here, because it's touching the eye, you can put tape. Actually, you can put tape back from the eyelid to open it up, or you can do surgery. You can refer same day if it's touching the cornea because you don't want the decreased vision. That is the most problematic thing. Other than this, if the eyelid is in the same place, it's normal, but it's only the eyelashes here, you see, that's touching the cornea, that's malposition. It's called tracheasis or tracheasis. The eyelashes are touching the cornea and causes the same kind of symptoms, but the eyelid is in the same place. Now, what do you do for that? You can do routine care, lubrication, or you can even remove the hair, epilation, okay, which means removal of hair. You can also test it with the fluorescent strip, like the green, and you'll see it, like you'll see eyelashes touching the cornea and damaging it. Okay, so you can test that. Other malposition of the eye are things like drooping of the upper eyelid. So, like drooping of upper eyelid, so remember, bleph means eyelid, ptosis means drooping. So eyelid drooping can be caused by like that. It can look like that. Now, main causes of this blepharoptosis can be in adults. We will say it can be either weakness of the muscle, so orbicularis, not orbicularis, levator muscle. So levator is the one that is supposed to keep our upper eyelid up, but it's not. So levator muscle weakness or nerve weakness, like cranial nerve 3, which is acquired, or Horner's syndrome can happen. Horner's is um, abnormality in the sympathetic nervous system, so it will also cause meiosis, like constriction of the eye, or it can be caused by myasthenia gravis, which is autoimmune neuromuscular disorder. Myasthenia gravis will cause drooping or ptosis of the eye, which is variable throughout the day. So it will cause drooping, um, worsen towards the end of the day, right? So that is the three causes in adults. In children, it's more congenital, drooping of the eye, and you don't want that to happen in children because it will cause something called lazy eye or amblyopia. I'll come to that in a bit. But basically, if the drooping is like that, happening like that in a child, and it's affecting, so the light is not going in their eye, right? It's more going on the normal eye. You don't want that because as they grow up they will forget to use, they will forget to use the drooped eyelid eye, and the vision will be lost here, which will cause amblyopia or loss of vision due to mis like due to lack of light source in early childhood. Okay, I hope that made sense. So lazy eye does not develop normal eyesight in the future. You want to be really careful of that. The main thing you look for is corneal light reflex. If you shine a light in their eye and they have that white corneal reflex, then that means it is okay, that the light is still going through the eye and they will develop normal vision. If there is no light reflex, that means that the light is not reaching that eye and they will have vision loss later in the future. So doing this test is very, very important. So, what about movement? So, we talked about eyelid position, malposition. Movement, it can be due to spasm. Blepharospasm is like involuntary spasm of the muscle around the eye. So, orbicularis muscle, all of it. You can treat that with botulism toxin, which will cause relaxation of that muscle and so Botox. It will cause relaxation and it will open up the eye. Hemiphageal spasm, same thing, spasm, but one side of the face. It can be due to seventh nerve compression in the brainstem. It can be present during sleep, intermittent. Okay, that is the key word. So it's important to do an MRI to see what is wrong with that nerve, if there is a compression, if there is a tumor in the brain. Seventh nerve palsy is like not intermittent, but it's one side of the face is affected. So this one, he's like, do you see here? Like this side is very, very much affected. It's not moving at all. So palsy is due to seventh nerve compression. It can be in the brainstem, peripheral, anywhere in the seventh nerve course, and a lot of things can cause it. Most common is Bell's palsy, which is seventh nerve palsy, the name of it. Okay. Seventh nerve course is important. Again, from your anatomy, it's important to know that it supplies your ear, like ear muscle, stapedius muscle, ear sense, and the taste from the tongue, and your muscles, of course, of the face, right here. Okay, so all the muscles of the face. The taste is from a nerve called chorda tympani. So T and T, that's taste. I like to know that that is for the taste. All of this comes from the seventh nerve. It's all interconnected with the ganglion and so on. It can also cause eye tearing. So lacrimal gland is supplied by seventh nerve. So all of this, lacrimal gland, salivary gland, taste, ear, all of this is done by seventh nerve. Let's talk about the tear gland itself. So if you look at the eye, we talked about upper eyelid, lower eyelid. This is the lacrimal gland that sits on top of your eye like that. It produces tears. When you blink, it goes to the that side. So that's why, like when someone is crying or they're tearing up, all of the eye is like wet, right? So ultimately it goes to the right, so inner side of the eye in the canaliculi. so something called like canaliculi and ducts, which will go into the lacrimal sac, which will go down to your nose. That's why someone who has runny nose, or sorry, tearing or like crying will have runny nose as well, because that all those tears go drain ultimately into the lacrimal sac and the nasolacrimal duct. So it goes ultimately into the nose. So this is gland, that is the sac. If the gland is affected, lacrimal, another name for lacrimal is dacryo. If the gland is affected, we say dacryoadenitis. Adenitis is gland. If the sac is affected, we say dacryocystitis. So cystitis is the sac, adenitis is the gland. So that these pictures are for the gland infection. So you see it's in the upper side of the eye, and then if you turn it, you will see it more inflamed. Whereas the sac is much more obvious because it's on that side, right? And if that gets inflamed, like dacryocystitis, you will see it on the inner side of the eye, inner side of the eye, okay? That is very different from the sty or the chalazion that we saw before, because that was on the one small lesion on the eyelid, whereas this is literally on the sac. All of this is red. Okay? Now, in childhood, in birth, if someone has nasolacrimal duct obstruction by any sort of reason, congenital or not, if this is blocked, then this will back up, back up, back up, and the tears will have nowhere to drain. So they will be stuck in that, they will have excessive tearing, overflowing of tears, right? And that will cause crusting of the eyelashes, and so on. So that obstruction will cause excessive tears. So obstruction is another problem. What can you do to treat that? You can first massage it like that. If you massage it, it's gonna like relieve that obstruction sometimes, and the tears can flow through. So massaging it is the first thing until they are like, let's say, 1 year of age. If that doesn't work, you can do probing and syringe like these. So you can probe the area and you can open that obstruction. If that doesn't work, you go into a more invasive surgery called dacryocystorynostomy. So you go from the nose and you kind of open up the whole blockage and open up an opening in the nose for it to drain. So massage first. If that doesn't work, you probe with syringe. That doesn't work, you do surgery, more extensive surgery. I remember we talked about cystitis and adenitis. Cystitis, which is the sac obstruction, looks more inflamed, right? So obviously it is more more painful and more redness discharge. It is caused by obstruction, and remember the again the bacteria staphylococci. Sorry, it's wrong, but staphylococci, strep, and diphthioids are the most common causes of infection that can cause this to happen. It can be also caused by obstruction leading to that. What is the treatment? You do systemic antibiotics because bacteria, and drainage with surgery. You can do that if it's severe. Dacroadenitis, this one, which is in the top of the eye, again, not as severe looking, so it only causes acute discomfort there, but it will resolve on its own most of the time. Dacrocystitis is the one that is more severe. Okay? Now let's talk about trauma. Trauma in the eye or the eyelid is very important in three cases. If it involves lid margin, if it involves canthal, or like canthal is here, uh, canthal is these sides of the eye, or canaliculi, which is like the draining ducts from the side, right? So if it's canthus is like the side of the eye. Canaliculi are the ducts that drain here. So if these three are affected in trauma, whether sharp or blunt trauma, you have to call an ophthalmologist. And this picture here is involving the canaliculi or the duct. So it's very disfiguring, and you have to call to make sure that there's no like more damage that's happening here. What about masses that can affect the eyelid? This is not that important, but it can be inflammatory or non-inflammatory, like neoplasm tumors. Yeah, inflammatory can be due to vasculitis, sarcoidosis, other systemic diseases. She didn't focus too much on that, and it's okay not to know that them all. Okay. Now let's talk about strabismus. Strabismus, we talked about eyelid, we talked about red eye, we talked about vision loss. Strabismus is misalignment of the eye, literally the one in bold. You will see it as like squint if you've seen it in children, like squint or crossed eyes. Some children have like that, right? That is literally called strabismus. So it's misalignment of the eye. This is normal, right? If one of them is not looking at the same time and it's like going in this direction, that is misalignment. That can be caused by damage in the muscle, so extraocular muscle or nerve damage. It can be caused by malposition of the eye due to congenital reasons. And in newborn, actually the vision is worse, but by age 2, they will have full vision. Like 20/20 is the normal vision. 20/400 is not good. So newborn will have not a good vision, but by age 2, they should have this sort of vision that we have as normal, right? Without our glasses. So 20/20. So in 2 years, it will grow like the vision will grow very fast. So if strabismus is important because it's an important diagnosis, like you have to diagnose it quickly in a child if you see it, because it can cause other things down the line. What are the symptoms? So child with strabismus will have like these obvious symptoms, but they can also have abnormal head posture to try to see something, or poor vision in one eye, or again, diplopia, double vision, lack of concentration, or neck pain because of they're trying to move their head, right? So this is the abnormal one. This is the abnormal one here, here, here. What do you notice in all of these is the light reflex. Do you see the one I told you about? The light reflex should be in the middle of the pupil like that. If it's not, then that means there is misalignment, okay? Doesn't necessarily mean that it'll cause the lazy eye that we talked about. I'll get back to that in a bit. But this is the different positions of the eye that can cause strabismus. So we have esotropia, which is converging, exo is diverging, hyper is upwards, hypo is downwards. And then it's important to differentiate from nystagmus, which is nystagmus is repetitive motion of the eye. So it will like it's like a tick, okay? So horizontal nystagmus, vertical nystagmus, rotation nystagmus. So it's not the same as misalignment of the eye or vision. It's more of ticks. That is nystagmus. So important to know muscles of the eye. We have 6 muscles in your anatomy. So 6 muscles, 4 rectus. So superior rectus, inferior rectus, lateral rectus, medial rectus. This is the nose. Then you have 2 oblique. So superior oblique, inferior oblique. Okay? So 6 muscles, and you have 9 movements of the eye, up, down, left, right, everywhere. 9 movements. And the nerves are cranial nerves. So third cranial nerve supplies everything else. The superior oblique is supplied by 4. Lateral rectus is supplied by 6. So SO4, LR6, I like to say. So superior oblique is by cranial nerve 4. Lateral rectus is by 6. So you have in total 3 cranial nerves, 6 muscles, 9 movements. Pseudostrabismus is fake strabismus. So what that means is look at the corneal right reflex. She will emphasize on this so much, and for good things. So if you suspect someone like this has strabismus, you might not be able to tell, right? Shine a light, and if that light falls on both pupils exactly, then that means this is not strabismus. So it's fake if the normal corneal light reflex is there. Why does it look like strabismus? That can be because of the eyes placement, like they are too close or they are too far away, or they can be because of epicanthal folds, like here, extra folds in the skin, and the nose looks big. Anything like that can cause it to look like strabismus. So I read somewhere also like Asians, for example, because or even like Down syndrome. So people who have eye placement that is like not or like epicanthal folds, for example, they can have they can look like they have strabismus, but they're not. Why do we need to detect it? Again, to prevent lazy eye. The lazy eye means like if you, so let's say you shine reflex here, okay? And one of them is not having that light reflex, that means the light is not reaching that eye to the brain. So that eye will not develop over the long period of their childhood, which will cause vision loss in the future. To stop this, you have to treat it before the age of 6 years old. So that is the cutoff for lazy eye or amblyopia. Amblyopia. So you have to treat it, the younger the better. Okay? So true versus pseudo, look at corneal reflex. This is how it should be. If it's outside the pupil, that is not correct. Okay, that is strabismus. And then you can do cover uncover test, prism test, things like, so cover uncover means covering the abnormal, so covering the normal eye, and then if the abnormal strabismus eye moves to the center, then that means it is at least milder than, than it's being stuck to the side. Like it can go to the middle if you just focus, if that makes sense. So cover uncover test, prism test, not too important, but just good to know. Prism test is to test the refraction, so how much someone can move their eye or like align their eye until it reaches that object, okay, so for the light to enter. And again, signs of strabismus is abnormal head posture, look at the neck pain and everything like that, okay? So someone who has strabismus will have uh, like those problems. Now, deviation of the eye, remember how I said these can cause strabismus or misalignment. So horizontal deviation can be either esotropia, like this, so meaning the eye is deviated inwards, 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 here, 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 here. If the eye is deviated inwards and you flash a light on their eye, that light will be towards where? Like towards the opposite, right? So that light should be in the center, but because the eye is deviated inwards, that light goes towards the outer side. So the light is now away from the nose. Okay, so the eye is inwards, esotropia is convergent, but the light is away from the nose. Okay, here the light is away from the nose. It should be here, but it's not. And hyperopia means, so remember the difference. So I'll talk about hyperopia in a bit, but hyperopia means farsightedness, which means that they can see far, but they cannot see near. So I'll come to why this is important in a bit. Exotropia means outside. So the pupil is deviated outside like this, like that, like okay, like that. When they're focusing on one object, that pupil goes outwards like this. But the light reflex is now, because it's outwards, the light appears closer to the nose. So the light reflex plus deviation is always opposite to each other. Okay? Now, there is something called accommodation. So accommodation is focusing on an object. When we have an object, let's say, that is coming closer to our eye, we focus on it because of accommodation. And usually, if an object is near to the eye, the ciliary muscles will contract. The ciliary muscles will contract, which will make the lens more round, good for closer vision. If an object is far, it stretches that lens. Okay, it becomes thin, but the ciliary muscles are relaxed to stretch the lens. That's how you can think about it. Okay, so that allows us to focus. In someone with esotropia, okay, so someone who is, let's start with this, hyperopic. So for me, for example, I am myopic, which means that I cannot see far objects, I can see near objects. So that's why I need glasses for my myopia. Someone who is farsighted, like an elderly, they can read far objects, right? They can see it, but when they bring newspapers or something, they cannot see that vision, right? Like it becomes blurry. That is hyperopia. So I like to remember this difference by saying like I am myopic, which means I cannot see far, but someone who can see far is called hyperopic, okay? So that is something you can remember. So hyperopic is farsightedness. They can see far. So when an object is brought closer to their eye, right, they cannot see that object as well. So that causes esotropia. So it's not real esotropia, it's just esotropia or convergence caused by this. Because they cannot see that, they are trying to accommodate for that. So their eyes converge and causes this fake esotropia or fake strabismus. Once you put glasses on them, they will start to be able to see, and it resolves that strabismus. So it's like reflex crossing of the eye, can see at a distance, but when it will cross when they try to look at something close, okay? Now, deviation, if it's vertical deviation, we talked about. Now, look at the difference. This is hyperopic, this is hypertropic, okay? So, esotropia, exotropia, hypertropia, hypotropia. Hypertropia means the eye is deviated upwards. So, automatically, that means the light reflex is down, closer, right? Light reflex is down in the down part of the eye. Hypotropia means the eye is deviated down, but the light reflex is up more than it should be. So opposite. What are the causes? It can be caused by a lot of things like thyroid disease, eye surgery, nerve palsies, and so on. Again, not don't bother yourself with the causes. Just remember that deviation and the light reflex is in the opposite way. What are the causes of strabismus on its own? Strabismus can be caused by, again, all these malposition of the eye is the cause of strabismus on its own. But many of them have high refractive errors, which means myopia or hyperopia, farsightedness or nearsightedness. If they are uncorrected, or even astigmatism, I also have that. Astigmatism means abnormal curvature of the eye. So when the light is, it's not it's not as important, but just remember any refractive error, any curvature like of the light that is wrong is can cause strabismus or misalignment of the eye. So this one is, do you remember that? It's converging, right? So the light is towards away from the nose, the pupil is inside the nose, kinda. So that one is esotropia, okay? Esotropia. So that can cause that can have underlying refractive error, so they might have the hyperopia myopia thingy that's going on. Some other eye conditions like opacity, lens opacity, cataracts, this tumor, huge tumor, this white reflex, any of these causes can cause strabismus or misalignment of the eye. Family history is important to ask about, and acquired like trauma, muscle, nerve lesion all the time can cause drooping of the eye, can cause strabismus. Okay, so someone cannot see or align their eye because of all these different reasons. More commonly in premature babies, developmental disabilities in African populations. Important to ask about birth history and examining the eye, and then doing the special tests. So light reflex, prism tests, cover and uncover tests, which will take later in 50 or more. Okay. What is the treatment? So you need immediate referral if it's the strabismus is in a child, because you want to like prevent that lazy eye from happening. So treatment for strabismus, if it's high refractive error like these, you will wear glasses like well, like me and other people. So if they have myopia, farsightedness, myopia is nearsightedness. Myopia means I cannot see far. I can see near. So myopia, and then hyperopia, astigmatism, anything that is affecting their vision, you put glasses on them. That is the first line of treatment. The second thing, if they don't have farsightedness or nearsightedness, if it's just the esotropia, like without myopia or hyperopia, it's just deviation of the eye, you can do patching. So patching means covering. So this is what we do in the uncover cover test. So patching is the treatment. once you cover the, so let's say that someone is here like this, okay, without the refractive error, without the like the error in their vision. So if you cover the good eye, the it will train the bad eye to see on its own. The bad eye will come to the center, and the light will be on it a lot of the times, right? So that will make it develop normally how it should be. So that's why you always patch the good eye to make the other bad eye work and not cause lazy eye in the future. So you can only do this if someone has unilateral strabismus. So if they're bilateral, you cannot patch both eyes because they cannot see. So unilateral strabismus, and if they have refractive error, you can put glasses on them. It's fine. So if they have both, you can put glasses and patch. If they have only the deviation problem, you can just put the patch. Okay. The last thing is surgery. You can either remove the muscle or move the muscle a bit, recession or resection of the muscle, and that can cause deviation to go back to normal. Or you can do Botox injection, which you will inject Botox to relax that eye muscle if it's a muscle problem, but you need repeated injection of that Botox. So these are treatments for strabismus. Amblyopia, which is the lazy eye, is very, very crucial to rule out. That's why you want to do diagnose, you want to immediately refer a child to make sure that it is like actually the light is going through or not going through by doing a simple corneal light reflex test. Amblyopia can be caused by strabismic, so untreated strabismus. If you don't treat it, it can cause lazy eye. It can be due to difference in eye power, so someone can have -8, -3, for example. And if you untreat that, that can cause lazy eye. The eyes will not develop as it normally should. Then you have refractive, so someone who is not, that's why you have to put glasses on someone. If they have untreated refractive error, strabismus is just the deviation. Refractive is the one that you need glasses. It can result in bilateral lazy eye, which you do not want at all. Then the fourth one is mechanical. Mechanical means something obstructing the eye from up, down, like tumor, hemangioma, and so on, drooping of the eyelids. So all of these can cause the eye to not develop in the future, okay, which is very, very bad. What is the treatment for amblyopia or how to prevent amblyopia? This is treatment for strabismus. This is treatment for amblyopia. First, if it's the deviation problem, do a patch. Put a patch on. If it's a refractive problem, put eyeglasses plus or minus patch. See? It's the same thing. So if it's a refractive error, if the error is in the vision, they cannot see far or near, whatever, put eyeglasses and the patching to prevent the lazy eye. If it's mechanical, something causing like this, do surgery to remove that mechanical obstruction. The treatment for amblyopia is the earlier the detection, the better. Remember the age, less than 6. If it's more than 6, you cannot prevent amblyopia, okay? Congenital causes of the eye, so congenital causes of, like, let's say the strabismus or um, eye conditions is in premature infants. Sometimes they can have retinopathy of prematurity, I think. So ROP means in premature babies, the eyes are not developed to begin with. So in the exam, you have to dilate and examine the eye to make sure if it's okay or not in premature babies. If you have this, so here, what is abnormal is the white reflex. Having red reflex is very good and it's normal. So that is important. This is good. This is good. If they don't have reflex or have a white reflex, that is the abnormal part. One of the most common causes of this white abnormal reflex or leukocoria is retinoblastoma, which is an emergency because it's a fatal tumor of the eye, very common in children, and not very common, but it's the most common tumor in children of the eye, and it can cause things like strabismus, glaucoma, uveitis, every other thing you can think of, and proptosis. You can, because of its very huge rapid growth. These are other causes of that can cause white reflex, like cataract. Not having red reflex can be anything. Infection, you don't need to know in detail, but yeah, coats is very, it's the abnormal vessels and everything in the eye that can cause that. Okay. It's a rare disease though. What do you see in retinoblastoma after you first examine with the ophthalmologist has to do the red reflex. If they see white reflex, they have to do a lot of fundoscopic exams. And then when they do an MRI, they will see calcification here. That is a sign of retinoblastoma. Okay. What is so someone presents with white reflex in the eye. What is the most likely diagnosis? Is it cataract, glaucoma, retinoblastoma, Coats disease? I said the most common in children that is very emergency is retinoblastoma. Glaucoma doesn't happen in children. Cataract doesn't happen, at least in children. Like most common, no. And then Coats disease is very rare. Cataract can happen in birth, but it's bilateral with infection, so not really like a tumor or causing white reflex. It's more of white opacity. Okay. Now let's move on to systemic diseases of the eye. Systemic diseases means diseases that affecting the body, affecting the eye. So they can be non-infectious, like tumor, endocrine, vasculitis, connective tissue disorders, or infectious, like TB or um, congenital, CMV, cytomegalovirus. So always ask about family history, ask about eye diseases in the family, and so on. Non-infectious causes can be tumor, so pituitary adenoma can cause compression of the optic chiasm, which can cause which of the following? It can cause bitemporal hemianopsia, right? So optic chiasm is the crisscrossing of the nerves, so it will cause someone to not be able to look at the sides. So that's the abnormality. So bitemporal vision is lost. It can also, non-infectious cause of systemic can be thyroid. So thyroid disease, someone has thyroid disease, can cause a lot of things in the eye. Things like lid retraction. So retracted lid, you should not be able to see that white part. It's scary, right? So, but in the eye disease, thyroid disease, it can cause inflammation and of the muscle and the fat around the eye because again of the connective tissue deposition here that can cause the eye to protrude out and cause exophthalmos or lid retraction or lid lag. So when you tell them to follow your finger like that, the lid will lag and it will like kind of droop or like it should go down like this, but it does not because it's stuck because of all these inflammation around the eye muscles. It can also cause irreversible optic disc atrophy. So here is atrophy. It's like damage of the optic disc itself. Another thing, diabetes, we talked about a lot before. It's the most commonest cause of blindness. Remember that? It's like the very, very sparse, like yellow spots all over. Can be proliferative, non-proliferative. Remember that, okay? I just put it here for you. Now, other things like poisoning can cause eye disease, like morphine. So someone who is an addict to morphine can cause constriction. So meiotic and morphine. And opposite, if someone is toxicity with vitamin A and lead, it can cause blowing up of the eye, like swelling. So that is called papilledema, which is like a huge swelling of the around surrounding the eye. So this one is morphine myopic, so very, very constricted eye. Okay. Now, other things, diabetes, hand in hand comes hypertension. So hypertension, you don't need to know the specific, like all of this, but there's changes in the artery. Again, the same thing with the sparse yellow spots and exudates. But other thing that you don't see in diabetes but in hypertension is something called cotton wool spots. Cotton wool spots are these small spots that are not really yellow, but they're like pale yellow and rounder, I guess. Not as like this. It's more discrete round yellow, okay? And they're around like the periphery of the eye. So this is in hypertension caused by vasoconstriction and arteriosclerosis. Skin diseases, you don't need to know all of this, but just know that anyone with skin disease, elastic disease, refer them to the ophthalmologist because they need to check their eye to make sure that that skin disease does not cause eye disease as well, like these. Okay, she never went in detail, so I would not expect you to know like all of that for the exam. It's okay. So for family history, sorry, for family history, um, ask about family history. So some things can be autosomal recessive, like albinism. So albinism is like white hair, right? Not having enough melanin. So that means also the melanin around the iris is not there. So it will cause whitish, like eye around the eye. The iris is very, very pale, and they will complain of photophobia. So sunlight is very bad for them, and they will be very sensitive because they don't have melanin enough. So other chromosome abnormalities like 13, 15, 21 can cause eye problems. Again, Down syndrome can cause like upward slanting the eye problems of the eye because of the epicanthal folds, if you remember. Other syndromes like Usher syndrome and LMB. LMB is like a fancy name. I don't know how to pronounce it. It's in the notes. But basically, both of these can cause retinitis pigmentosa from the name pigments around the retina. So pigment dark spots all around the retina is retinitis pigmentosa. They can cause vision loss. Again, these are part of syndromes that comes with night vision loss, nyctalopia. So night vision loss plus retinitis pigmentosa. If that person like with both of these has inability to hear, that is Usher syndrome. Okay, so Usher is like hush, so cannot hear. LMB is the another thing. So if someone has retinitis pigmentosa plus night vision plus extra fingers, that is LMB. Okay, without the hearing loss. So these are two different things. LMB is extra digits. Ushers cannot hear, but they have same retinitis pigmentosa in the eye. Phacomatosis is like, if you remember the neurofibromatosis, all those neurofibroma diseases that you've taken in neuro. Oh, just give me a second, sorry. Oops. Okay, sorry, I had to stop for a bit, but let's start over from here. Yeah. So as I was saying, for again, talking about non-infectious systemic diseases, phacomatosis is one of them. Phacomatosis is, if you remember neurofibromatosis from your neuro lectures, it's like autosomal dominant most of the time, and the main issue with this is they have hamartomas in all over their bodies. So hamartomas are like benign growths of tissue. It can be, it depends on the disease. So the most important for this lecture, we will not care about these two. It's neurofibromatosis, NF1 and NF2. The first one, type 1, is also called von Reckling-Hongsen. It's a very long name, disease. This is the most common type, and it's the most common in terms of this disease, okay? And the way you can diagnose this is look at these four pictures. What do you see here? If you remember the dark spots, they're like the cafe au lait spots. That is very important for this diagnosis. And then you see here these three. This looks like chalazion to me, right? Do you remember the eyelid swelling? But this one in this systemic disease, if you look at the whole person, like their disease itself, it's like a hamartoma from the neurofibromatosis. Now, this eyelid neurofibroma can cause ptosis and glaucoma because of which we'll talk about, its increased intraocular pressure in the eye because of all these issues. There's also deposits that you see, like brown deposits here and there. These are called Lish nodules, and in 95% of them, they are there, present. And then white lens opacity is cataract. Okay. The other disease in this case is Sturge-Weber syndrome. This is the one that I like to call the one with the port wine stain. It's like red stain all over one side of the face. It can involve the eye, of course. Another name for this is called nevus flammus. So it's like a flame or like nerve, like that's how I remember it. It's like red, okay? Again, there's no pressure, it's congenital. The same thing problem can occur here. That's why it's in bold and in capital, glaucoma, okay? So you have to send them to the doctor to see and check their eye every time. Other causes, very, very common or familiar connective tissue disease is Marfan. So Marfan is also autosomal dominant. This is the actual red reflex and the lens that you see here, but in Marfan it's dislocated or subluxated where the direction is important. You should always say Marfan has upwards and outwards dislocation of the lens. Now that can also be called superotemporal, okay, upwards and outwards. Remember this picture. So there are people with tall who are tall with long fingers, long hands, and so on, and scoliosis and other flexible joints and stuff. Now, the other condition, connective tissue disease, the other aspect is vasculitis. So, vessel diseases like giant cell arteritis causing medium sized vessel vasculitis. This is urgent because it can cause very severe vision loss and blindness, and you don't want that. So, it can affect the vessels in your scalp, the temporal arteries, and so on. That's why you have scalp tenderness, headaches, and like it affects it like that. Okay, and if it affects the eye, and it can also have something called polymyalgia, which means pain over all your limbs and your weakness and so on. There's also constitutional symptoms, and basically, if it affects your ophthalmic artery, like the artery of the eye, that can cause vision loss. So you want to do like quick treatment, immediate treatment for that. Take biopsy and then give steroids empirically to reduce that vasculitis. And then myasthenia gravis, if you remember, it was the one of the causes of blepharoptosis, which is the ptosis of the eyelid. It's an autoimmune neuromuscular disease and can involve the eye and can have variable ptosis. Okay. This one is intranuclear of ocular neuropathy. I forgot the name of it, but it's another condition with myasthenia gravis. Wait, let me search it up quickly because I forgot the name. Um, Intranuclear ophthalmoplegia, plagia. But basically, that's a issue with the nerves in the eye. You don't need to really know it in details for this lecture, but just remember that it can cause variable ptosis throughout the day. Okay. Okay, so this one is again giant cell arteritis. What do you see here? You see swelling edema around not clear optic disc, so it should be circle, but here it's like just spilled over, right? Only around this area. That is what we call papilledema, which is increased pressure in the eye, in the back of the eye. And then this one is your the artery and showing you the inflammation and everything around the temporal artery. Okay. Now, what do you see here? We see, I'm not gonna show the name, but it's a systemic disease that can cause like peripheral damage to the eye. And you see here one side, it's like like it looks milder with intact epithelium. It looks like a contact lens. You can say that. This one is more severe, diffuse circumferential, but very acute and painful. This is chronic. This happens. These two manifestations can happen in rheumatoid arthritis, which is another systemic disease, if you remember, with peripheral cornea damage with inflammation, that one, and then without inflammation. Okay, so two manifestations. Other things that you can, if you remember, one of the other one with rheumatoid was episcleritis and scleritis, right? If you remember, that was the systemic disease. Now, if you see in the anterior segment of the eye from the front and then posterior segment, you can tell some systemic diseases from the start, from just like your vision from this. So the first thing in interior, you don't need to know all of it, but again, these are just examples for you. So do you see here? These are called Kaeser. I can't say the name. Kaeser rings, the one with the copper deposition. And this is in Wilson, if you remember. So I'll reveal them one by one. But yeah, this one you see are yellow spots. Again, you don't need to know them, but cystine deposits. This is again another clear rim of yellow. It's like cholesterol. So that's in like the fat deposits. These two are the same. It's right there. They're cataracts. Can happen in different conditions, different congenital diseases. These are brush field spots, like brush field, it's like paint brushes, right? That can happen in things like Down syndrome. So these are cataracts, you don't need to know the name. This is brush field Down syndrome. This is Wilson, cystinosis, cystine deposits. This is another condition causing cataracts, and this is hypercholesteremia. What about in posterior side of the retina? You see here inflammation, right? What she pointed out, or what I like to think is like more important, are these, like if you see multiple dots of white yellow, this looks like metastasis. Oops, this looks like metastasis of like tumor in the body somewhere else. These are neuropathy, so the optic disc is light pale and stuff, it's not bright, so any neuropathy can cause that. If there's hemorrhages like there, like this, similar to metastasis, but we it's another type of cancer, leukemia. And then hyperviscosity, if you see the veins or the arteries are very, very tortuous, that's hyperviscosity syndrome. Okay. Again, these are again examples. I haven't seen them be brought, so let's like just know it's good to know them. So which lid condition has systemic findings? Which of the following? I'll let you wait a bit and then I'll answer. So the answer is this. Okay. So what is this? So remember, this is opacity. Okay. Just opaque cornea. And that one is not systemic. It can be a lot of other things. This is squamous cell carcinoma. It's cancer of the skin around the eye. So it has no systemic findings unless yeah, it's not metastasis. It's usually primary. This is chalazion, the chronic blockage of the Melbovian duct or gland. So it's not systemic. This one is scleritis. So the one with purple color, thinning of sclera, has associations with systemic rheumatoid arthritis, SLE, and so on, right? So remember that. Even episcleritis, by the way. Infectious causes of systemic diseases can be in childhood, like congenital diseases that can pass from the mother to child, like syphilis, rubella, candida, toxoplasmosis. If it's affecting like bilateral cataracts, it's syphilis and rubella can mainly cause that. If it's white spots like that, it's candida because it's fungus. This one is like in the macula, the dense part. If you see red like black deposits, that's also rubella. And if you see yellow and like we call it inflammation of the chorioretinitis, it's toxoplasmosis. Okay, so retina damage is toxo, macula alone is rubella. Okay. Herpes zoster we talked about in detail, the midline aspect, the distribution of trigemina. So I won't. That's why it's a very small picture here, but it's still infectious, and chicken reactivation of chickenpox. Then you have HIV. So HIV is a very systemic disease. 70% of them will have eye manifestations. So they will have this. They can have something that looks like pizza, kinda. Like red and yellow dots everywhere. Like it's in a slice of pie kind of thing. So this one is associated because of HIV being immunosuppressed. So they will have infections like CMV, cytomegalovirus, that can cause chorioretinitis, which can cause necrosis and vasculitis, and so on. So this is similar to this one, toxo. They are very similar. They are both chorioretinitis, but this one is in HIV, this one is in infection, another infection. Another tumor related to HIV is something called Kaposi sarcoma. There's no picture for it that it was provided, but it's just this tumor related to HIV. Just remember Kaposi sarcoma. Okay. Now we'll move to glaucoma and more details about the drugs. So we finished with the eye lectures, we'll move to this. So what is glaucoma? I told you that like everything else, the eye has its own fluid pressure called intraocular pressure. Now, this intraocular pressure is by the fluid around the eye, mainly the anterior chamber here. So I'll just talk about the anatomy first. So we have sclera. This is the front of the eye, anterior chamber, with the iris and the lens separating it from the posterior chamber, which is here. Okay. Now, these are spaces that are filled with fluid. Where does this fluid come from? This fluid comes from a cell, which is called, in this case, ciliary epithelium or ciliary body. This ciliary body, ciliary epithelium, ciliary body, releases fluids called intraocular, like that can cause the intraocular pressure, but basically they're released from the posterior side. Then they go through the between the lens and iris, go to the anterior and just fills it, okay, like that. This keeps it going and then it has to drain somewhere. So it drains into a hole called canal of Schlemm or Slem through something called the trabecular meshwork. So you see these trabecle, these lines, it goes through there and then drains back into the blood. So this continuous drainage is just like our CSF, just like our blood and lymph nodes in the eye. It just keeps draining like that. There's another pathway where it drains into. So if you see here, let's reorient ourselves. This is ciliary body from posterior chamber to anterior side, and then goes into this hole, right? So this hole, this is a hole, the trabecula. This is called the trabecular outflow. Some of it will seep through into like the muscles, the ciliary muscle and the body again, but it will go to the blood eventually, but it just seeps into other like this loose openings. This is called the uveoscleral outflow. So sclera, from that sclera path. Now, these paths are outlined in this, but main thing is again what I said. The main pathway is trabecular meshwork, which is this through the hole. This is pressure dependent, means the pressure just pushes it into back into the hole. Okay, whereas this one, the small sclera openings, it goes through the ciliary muscle and the suprachoroidal space, which is that layer here above the above the choroid below the sclera. And then through relaxing of this muscle, it goes through this called the scleral outflow, which is not pressure dependent. Now, the anterior chamber is between, again, anatomy-wise, anterior chamber between the iris and the cornea, whereas the posterior chamber is between the iris and the lens. So posterior, anterior, okay? These are important borders to know for your exam. Just saying. So you can easily tell from the picture, you can draw it out and see where they are. There's space here, space there, below and before and after the lens. Now, meiosis, so two things. If meiosis means the lens, meiosis means the pupils constricting, yeah. So if the pupils constrict, right? If they constrict, it's gonna, the iris is gonna, like, it will go like this. If you can imagine, to constrict the lens, this will contract. Um, and this will open that angle or outflow, which is good. If there's dilation of the lens or the pupil, it like pushes on this opening, pushes on the anterior chamber and closes this angle. So that narrows the angle. So let's say some drops. So you always want a constant pressure in this. If the hole is closed for some reason or it is narrowed, then the pressure will back up and increase here, which you don't want. So things like eye drops or medication that can dilate your pupils and narrow that angle is a very risky thing. Again, it's our pupils dilate normally, which is fine, but in someone who has abnormal structure to begin with, or they have high intraocular pressure due to any other reason, and they put something that opens their eyes wider, it can cause narrowing of this angle and the pressure build up in the chamber. This is called glaucoma. Glaucoma is increase in intraocular pressure due to either the blockage of the drain or you have increased production of from the cells themselves. Okay, so two pathways. So glaucoma is the second leading cause of blindness. First was diabetes. It's the increased intraocular pressure that can compress the optic nerve and cause damage and atrophy and cause this optic cupping that we saw before in the first few slides. The vision with glaucoma starts with vision loss in the periphery, and then slowly, they will start losing their central vision. If no optic nerve damage, then it's not glaucoma, it's just a hypertension, ocular hypertension, okay? But it has to have optic nerve damage to be called glaucoma. It can cause irreversible blindness. So the treatment for this, the one in pink, is to decrease the intraocular pressure. The normal is 8 to 21. If it's more than 60, more than 25, that is increase, like too much increase, so you don't want that. And the treatment for this is pharmacological, laser, or surgery. Our focus is pharma, so we'll focus on that. The types of glaucoma are two types. There is the open angle glaucoma, and then there is angle closure glaucoma. Now, what is the difference? Open angle, from the name, the angle is open, okay? Like the this angle is wide open and it can drain. It's just something wrong with the, let's say, either it's slowly draining for some other reason or not because of the angle, okay? So this happens over a long period of time because the angle is open and it can drain. It happens with inadequate drainage, maybe with age, everything slows down, sort of something like that. So progressive first periphery vision loss, and then it goes to central. It's very asymptomatic, and it's um, sometimes called silent thief. Like it takes the vision away, and no one really notices it until they start to lose the central loss, which is too late at that point. Um, sorry. For this risk, the risk is already having an intraocular pressure, age, family history, diabetes with everything, myopia is one of them. The treatment is to stop the progress and to early detect it. That's why you have to always do an eye exam, especially in elderly, to make sure, and especially someone who has diabetes, they have to anyway go for the exam. So they have to make sure that with the tonometer to measure the intraocular pressure and make sure that it's not increased pressure over time. So this is the optic disc cupping. This is increased pressure over the eye. Okay. Now, this is like a, I don't know, it was in the lecture. It looks like a foreign body to me, but I think it was pointing at increased pressure somehow. But don't worry, he won't give you something that's not clear. If it's angle closure glaucoma, which is the angle is itself is closed, so that happens acute and very sudden, and it increases the pressure to more than 60 sometimes. So both are inadequate drainage, but this is very acutely, this is over time. Angle closure is very acute, so close and acute. Sudden onset must be treated within 24 hours. This is an emergency. Signs of acute closure glaucoma is edema of the eye, the first thing that we saw, remember the first slide with opacity, shallow anterior chamber, so anterior chamber is very less, and tearing, and mid-dilated pupil, which means the pupil is stuck in that size because it's not able to constrict or dilate anymore with the closed angle. Poor reactive pupils, they will not react to light. You have opacity and so on, and redness, swelling. See the difference? This is dilated, mid-dilated pupil, and it's stuck in that position. You will also have, they will also have headache, severe eye pain, lights, halos, nausea, vomiting, everything that increases with intraocular pressure. Intracranial pressure is the same thing here, and it's very narrowing of the angle. So be very careful. Now, the treatment for both of these is very different. Chronic, so obviously there are pharmacological agents that can reduce, so the goal is to reduce intraocular pressure, okay? In open angle glaucoma, you have drugs that will suppress the cells from making fluid, or you have something that will increase that outflow, okay? So increase outflow or decrease fluid production. So these are all the agents, but anyway, you can remember them. Suppressing is by blockers, so ABC. Okay, so ABC blockers. Beta blockers. So alpha agonists are in a way blockers because if you remember, these are alpha 2 agonists, which means so when you talk about alpha 2, do you remember from first year that the alpha 2 is actually inhibiting its own signal? So in that way, alpha 2 is inhibiting its own nerve production or signal. So that is inhibiting or blocker. So alpha agonists, just remember that they work by blocking the production. So alpha agonist, beta blockers from the name, and then carbonic anhydrase inhibitor or blockers. So ABC. Beta blockers are the ones ending with lol, lol, lol and stuff. Alpha is alpha is like um prime, like the alpha, right? Like it's very important. So it ends with dine. So like fine dining, something like that. I don't know. Anything to make it work. So alpha is very prime. So like they all end with dine, 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 dine. Okay. Carbonic anhydrase inhibitor C is amide. So anhyd an inhibitors, amide inhibitors, okay? I don't know if that makes sense, but anhydrase, amide, amide. Now, that things that increase the outflow are also kind of like ABC, but it's P instead of B. So you have alpha, the same agents. C is something else now, cholinergic agonists. So cholinergic agonists from the name chol, so pilo and carbachol, okay? Pilocarpine and carbachol. And this one kind of mixes with the second name, pilocarbol, okay? So that is cholinergic agonist C. The P or the B in this case is prostaglandin analogs. So prost, anything that ends with prost is prostaglandin analogs that increase this outflow, okay? Now, other new drugs are rho kinase. We'll come to this, netarcidil. So these are synthetic drugs that inhibit like the rho kinase, and then there's another one, this synthetic omidenepag. Okay, so weird names are separate drugs. Now, in open angle glaucoma, you do like to use, so the one in red boxes, ignore them. The one in red boxes are for the closer angle closure glaucoma. For the open angle glaucoma, first line, again, we do not want to use combination for someone who has chronically like this disease progress. You just want one drop over like once daily and stuff, right? So the first line for open angle glaucoma is prostaglandin analogs, which is increasing that outflow. The angle is already open, so you just want to increase that going out. So prostaglandin analogs is first line. If you want to use combination, you can do beta blockers, which is that one. So P is first, right? Prostaglandin analogs, and then the other combinations are other combinations. You don't need to remember each of them. They're just different combinations of all these drugs. Now, this is the table. So these two are the tables for the drugs. Increasing outflow is again this one. So P and the weird names, drugs, and the cholinergic agonist, right? The alpha is in green because it's actually helps with increased outflow and decreases the production. So alpha is green, this is yellow, and then that is blue. Okay, so let's start with the first line treatment for open angle glaucoma. They can come in eye drops, they can come in single use vials that to reduce like allergies and stuff. This is inside the eye itself so that they don't have to put the drops. And then there's other serum type things. Anyway, these are analogs to prostaglandin F2A, which are found in the eye. They cause increased outflow, primarily through which pathway? Through the pore pathway, uvoscleral outflow. Why is that? Because again, like I said, the angle is already open. There's something wrong or slowing down. So this prostaglandin actually helps it go through the other way around, like the pores, and then it also helps with this secondarily. No need to remember the numbers, but remember it's first line because it's well tolerated. What are these side effects? Side effects, everything will have side effects like eye irritation and stuff. So they're not specific. What is specific to prostaglandin analogs are the ones in bold. So things like pigments. So prostaglandin analogs, they are growth, kind of like growth analogs, right? They increase growth. So your iris will become darker, your lashes will grow, And it will, because of this growth and melanin increase, the fat around the eye will decrease. Okay, so the fat will not be helped, it will cause atrophy, while the lash and everything else around the eye will increase in melanin. So that is something not good, because you will have imbalance like eyelids, eyelashes, unless you have glaucoma in both eyes. It's not a good cosmetically, like it's not a good thing. They do not work in angle closure, even though they are first line in angle, open angle. In close angle, you do not use that. So that's why you see the red boxes are for close. You do not use prostaglandin analogs. Now, this one has the same mechanism, but it's prostaglandin agonist, which means it's a synthetic form of this. So only the PAG is prostaglandin, PAG. Again, same thing, same action, mechanism of action, primarily this, but it doesn't have the side effects. That's a good thing. But it's expensive, so we always stick to this, even though it has these side effects. Okay, no need to, this is just very non-specific. What about the new drug Rho kinase inhibitor, netarcetil, the other weird name? It inhibits something called Rho kinase, which Rho kinase usually uh, puts a phosphate, and then it increases the contraction, okay? Contracts the ciliary muscle. But if you inhibit the Rho kinase, it will cause relaxation of the muscle, which will cause, remember, if you like, it relaxes that angle and opens it up more if it relaxes the lens. So it increases trabecular outflow in that case, okay? Because it opens the primary angle that we talked about. Cholinergic agonists is like the col, so pilocarpine, pilocarbacle. These are M3 agonists, which are the muscarinic 3. Anyway, just remember these increase the outflow by causing ciliary muscle contraction. So contraction, cholinergic and contraction. It has few systemic side effects, like it can cause cramps and bronchospasm. Remember, contraction can cause these side effects, okay? These are not causing contraction. And the other thing is, because it causes contraction, it causes meiosis, so it causes fixed pupils in small size, and that's not always good because it can cause spasm with that, cause visual disturbances and headache, because the pupil is always constricted, and you can feel like if the light is not going in all the time, you feel a headache, right? So that is a bad thing for cholinergic agonists. What about ink? So this blue, like I said, is for decreasing production. So blockers, beta blockers, anti-sympathetic. Alpha agonist works both ways. But yeah, so that's why it's in green. And then remember, this one, carbonic anhydrase inhibitors, it inhibits the enzyme that produces the uh, fluid. Now, beta blockers like timolol and betaxolol. Timolol is non-selective, while beta is like selective, beta 1. So these are cheaper alternatives to prostaglandin, so they can be second line. They are second line otherwise, if someone cannot afford, like if someone can afford prostaglandin, this is second line. If they cannot afford, then this is first line. So they are once, twice administration. Side effects. Beta blockers, especially if non-selective, but even with selective, it's not good because it can cause systemic absorption, which means if they apply it in one eye, it can like decrease the intraocular pressure in both eyes and cause things like other beta blockers do. So bronchospasm in asthma. You cannot use that. Bradycardia, so heart rate decreases, worsening of heart failure. These are more important and specific, so you should not and never use them in someone with cardiac or pulmonary disease like asthma or blocks, okay? Heart blocks. Carbonic anhydrase inhibitors, the only thing is if they have sulfonamide allergy, they will have hypersensitivity reaction. That's it. That's all. Allergic reaction, which is very common with anything. Alpha agonist works both ways, so it tackles, it's a very good medication tackling both this and this, increasing outflow and decreasing production. Again, alpha 2 with dyne. This is a side effect, okay? So alpha agonist, like always, will cause vasoconstriction of everything, and it increases the uvoscleral outflow, because remember this, if you have relaxation of smooth muscles, right, it will cause increase in outflow. So here, if it constricts the vessels, then the muscles will relax and kind of increase that outflow. What is the side effect? What you see here, you see similar findings to allergic conjunctivitis. So red eye with like tiny bumps and follicles that you can see. So it can cause ocular pruritus and irritation and red eye, and it can cause systemic vascular insufficiency because it vasoconstricts blood vessels in general. Okay. So, summary, this is a very good table. If you don't like these tables, this is a very good one. So, alpha agonist is both, right? Yellow is only increasing outflow. Blue is decreasing synthesis. So, blocker, and so on. So, we talked about beta blockers. It's used in okay, we'll talk about that. The other thing I didn't talk about was diuretics. So diuretics, it decreases synthesis of any fluids. It diuresis, like it increases urine, right? So it decreases the fluid in the body. So one of them is called acetazolamide. Again, another name for that, we talked about it, but acetazolamide is this one. Carbonic anhydrase inhibitors. It's a diuretic as well. Um, Now, again, these two decrease, these two increase. This is for both. Remember, these are the side effects. So, prostaglandin is the one that causes darkening of eyelids. Cholinomymetrix is contraction of the muscles. So, ciliary muscles causing constant miosis and spasm. Alpha agonist will have blurry vision, foreign body sensation, something like allergic reaction. Okay. And yeah, ignore epinephrine. We didn't talk about that here. Okay, first line. First line in acute open angle is prostaglandins only. That does not work in closed. Everything else is closed. Okay, so just remember prostaglandins. P is for open angle glaucoma that takes over a long period of time. It's 1 drops, right? 1 to 2 drops. The rest of the medication can be used in angle closure glaucoma. Now there's a, see here, it's the same thing. Open angle, prostaglandin, second line is everything else. Acute angle closure, because it's more severe, you want to use combination. So you will use beta blocker, alpha 2 agonist, pilocarpine. So beta blocker, alpha 2 agonist, pilocarpine, and diuretic if you can. Carbonic anhydrase inhibitor. So everything else is acute closure. P prostaglandin is the only one for open angle. Okay. This is another diagram to show you, but I think for me, I like this one. But you can remember decreasing outflow is A, B, C, but increased trabecular outflow is things like prostaglandin here, some of it at least secondarily, and rho kinase is the first thing that it opens, right? Prostaglandin, the main pathway it opens up is through the uvascular outflow, same as alpha agonist. Alpha agonist works both ways. I hope that made sense. You can use any table, any diagram to help you with memorizing that. But this is a very, very good summary. Again, we're done with the lecture. So we'll go to questions and side effects. Oh, sorry. Before this, there's angle closure. But anyway, side effects, you have eyelash growth, darkening of the iris, and fat atrophy. This is side effect of prostaglandin. Prostaglandin, the only one that's used in open angle. This one, the one with follicular, like it looks like allergic conjunctivitis, is with alpha 2 agonist with the dyne, okay? Follicular conjunctivitis. These are with prostaglandin. So, in someone who is coming with acute presentation of very red, mid-dilated pupil in acute closure glaucoma, you use everything else except prostaglandin. So, you have beta blocker, alpha 2 agonist, pilocarpine, and then the carbonic anhydrase given IV, so systemic. It's like reduces body everywhere. Um, so this is systemic, so you give them through IV. This is topical, so drops, so you have to give them one at a time. So 1 drop each, 1 minute apart, and then once you give all of that, topical plus IV, you assess their pressure after 30 to 60 minutes, and then if still high, you repeat the whole thing. If it's controlled, you go and immediately do laser surgery and it remove the part of the iris and the pressure because it's emergency and you want to do that surgery quickly. This is just to control the pressure before the surgery, but this is the entire treatment for this emergency um, situation. So they are, anyway, people who are predisposed, they have narrow anterior chamber in the first place. They are not advised to use something that can cause dilation of the pupil and narrowing of that angle, like anticholinergic. Okay, so anticholinergic. This is cholinomimetic to open the angle. Anticholinergic will narrow that angle. So you do not want to use that in someone who already has narrow chamber, narrow angles. Okay, time for questions. We're done. So because it's a recording, I'll try to go over them quickly and you can pause them before you answer. So pause them before I answer. What is the appropriate management for a patient who presents with this? What is this first? This is because it's refined, confined in one. If someone wakes up with this is subconjunctival hemorrhage, and you just observe. You do not do anything. It's not an emergency situation. Which drug is most likely responsible for these symptoms? So you see in the right side, darkening, eyelash, atrophy. This is prostaglandin. What is the first line for? What is the condition? Open angle glaucoma over a long period of time. What is the mechanism of action? It increases outflow mainly in not through the not through the angle but through the pores. So B and A, both of them, it will increase outflow, but more of B than A because the B is like the pores, uvascular pathway, than the trabecular meshwork pathway. So mainly in B and A. Okay. Patient presents with sudden onset vision loss. Which of the following is most likely involved? By the way, these are from past, so you can you can trust me on these questions. Like these are important points from the lecture. So if a sudden onset vision loss, what is the most common one? We said retinal artery occlusion can acute vision loss can happen, yes, with cherry red macula. Optic nerve compression, not really. Virtuous hemorrhage, it's also acute loss, but the most common second cause leading blindness is due to glaucoma, so always go with that. So impaired drainage of aqueous humor can cause that. Someone coming out of a dark room, theater, like with their like eyes dilated, that causes them at risk for this kind of condition. So be careful of glaucoma. Close angle acute glaucoma. What is the first line treatment? Everything other than prostaglandin. So things like timolol, beta blocker, alpha 2 agonist, pilocarpine, topical, plus IV diuretic like carbonic anhydrase inhibitor. Patient presents with erythemus tender swelling of upper eyelid. Which of the following is most likely responsible? What do you find in gram stain? This tender swelling on the upper eyelid that is red and acute is a sty. It can happen in adults and children. If you remember, what is the most common cause of sty is staph abscess. So gram-positive cocci in clusters. Okay, different from bacterial conjunctivitis, which can have other like strep and stuff. And it's different from another condition as well, which can cause which was one I forgot which one, but yeah, I did mention that there's like other things that can cause it, right? Like diphtoids and so on. With staph and strep, same thing. But staph for sure is wait, let me go back quickly. Staph for sure is the sty, okay? Um, okay. I remember I had it somewhere. Yeah, this one. Dacrocystitis is these three. Dacro is the tear gland thingy. Okay. Okay, we'll go. We talked about a lot of things, so I'm sorry if it was a lot, but hopefully you can stop and yeah. Okay. 58-year-old presents with irritation, foreign body sensation, redness. Eyelashes are seen to be misdirected, rubbing against cornea. Which one is the diagnosis? So eyelash misdirection is trichiasis. Entropion is the eyelid going inward in. Blepharitis is inflammation of eyelash. Chalazion is the chronic sty-like picture, but chronic. What is the type of conjunctivitis in all of these? So again, purulent, what is that? Bacterial. Very big, giant papillae bumps is allergic because of their itching. This one, the follicle, something that's mild red, tiny bumps is viral infection. Okay? Do we use cold? So the viral one will have a history of family. Someone in the family recently had a cold, like their sibling or someone, a child, like that. That will cause viral conjunctivitis. Do we use cold or warm compressors? So we use cold for viral and allergic because we don't need, it's not as severe. Warm, we use it for bacterial, and blepharitis, anything bacterial, sty, anything is warm with bacteria. These two are not bacteria, so cold. Which one requires immediate attention by ophthalmologist? I'll give you a second. This one. Why? Because this is dry eyes. Okay, it's common, it's very mild red. This one is confined, so it's subconjunctival hemorrhage. Even though it looks bad, it's not really that bad because it's confined and it will resolve on its own. It's just a bursting temporary of the blood vessel. This one is scleritis, kind of, so episcleritis above the sclera. This one is the chalazion, chronic, and yeah, it's not, it can be done routine referral. This is eyelid trauma involving the canaliculi, so you want to treat it as soon as possible because you have to call an ophthalmologist if it's involving the lid, canaliculi, or canthus. Which one is true strabismus? How do we know? This is, you're looking at the light reflex. If that light reflex is dot like in the center here, center, 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 it's okay, it's normal. The one that is not in the center and away from the pupil a bit towards the away from the nose, oops, that is the true strabismus. These are false strabismus. Okay, look at the corneal light reflex. This is esotropia, which is inside, right? And the light is out, towards out. Treatment for this, first thing, if this person does not have refractive error, like they can see far near properly, the first thing is patching the good eye so that this can go back to normal. Patching this good eye can let them see through the abnormal eye and then develop their vision later on. If they have refractive error, like myopia, like far sight, near sight, you can put patches with glass, both. Okay, but patching is a first line treatment if they don't mention refractive error. What is a common cause of the other three? False strabismus. So things like epicanthal folds, loose skin folds, ptosis, um, yeah, a lot of the broad nose, uh, eyes that are closed, anything you can say. So all of these epicanthal folds are common cause of causing it to look like strabismus. Which of the following is a characteristic of proliferative diabetic neuropathy? Proliferative is the one with new blood vessels, so neovascularization. Drusen is for macular degeneration. Cotton wool is hypertension. Virtuous hemorrhage is something else, which is non-proliferative, or it can be caused by, yeah, other things. In corneal abrasion, which of the following layers of the eye is affected? Which layer? So there's 5 layers of cornea. Abrasion is only the first layer. The rest is ulcer, corneal ulcer. 18-month-old visits a practitioner, reported disturbances in vision. Upon this exam, the general practitioner reported that there is a mass in the patient's baby, like the eye. The patient was then referred to ophthalmologist. Which of the following is the appropriate first thing done by the doctor? What do you do first? Concern for this retinal mass is obviously emergency retinoblastoma, but as an ophthalmologist, they would re-perform the test with the right light reflex, red reflex. They have to see if there's white reflex or the actual mass before going into doing MRI or CT. So re-perform the exam again and then see if it's concerning for retinoblastoma. 64-year-old losing his vision gradually over time. Which of the following could be the cause? Gradually over time. Oh, yeah, cataract. Okay. Why is that? Okay, so there were two questions about this. They should specify here that this is acute angle closure glaucoma, then that's not the answer. And then the other thing that I want to mention is if you get a question that's unclear between glaucoma versus cataract, just remember glaucoma is silent. The person will not lose, like, they will not um, realize that they're losing their vision until it's too late. Whereas cataract, they can tell because it's opaque and white, and they will be able to lose that vision with the blaring, like glare, white lights and bright lights and whatever, right? So glaucoma is silent. And that's why they do not realize it, even though it does take away their vision over time. Cataract is more noticeable. Okay? And then obviously if this says acute angle closure, that's not the answer because that one happens acutely. So this would be the glaucoma if it's open, chronic, open angle glaucoma. A patient who had AV block visited the hospital for glaucoma, acute glaucoma. Which of the following should be used, not be used in this patient? So if someone has AV block like heart, we said beta blockers. If you don't see beta blockers, go with something that will cause systemic vasoconstriction or vessel problem like alpha agonist. So dine, alpha dine. Okay, we talked about that. Another class that is contraindicated is beta blockers. If you see beta blockers plus alpha, go for beta blockers. Beta blockers are the more correct answer. But if you don't see it, alpha works too for this. Okay, but beta blockers should be the first contraindication because beta blockers will cause heart blocks anyway and asthma problems. Which of the following drugs helps reduce intraocular pressure by decreasing production of aqueous humor? Production of aqueous humor, we said ABC blocking the production, right? So A was alpha, I don't see dine anywhere. B is blockers, I don't see lol anywhere. C was carbonic anhydrase. Um, yeah, so amide, remember anhydrase inhibitor, amide, okay? Prostaglandin is not for the, like the eh, production, and this one is also for the outflow. Okay, this is something else we didn't take in this lecture. Patient with diabetes mellitus noticed sudden decrease in vision on exam. Diabetes, okay, sudden loss, no red reflex, so corneal opacity, no details of fundus. So when they look in the fundus, they cannot see anything. So that means that there's something blocking, right? That then the answer is, what is it? Virtuous hemorrhage. Why is that? Because we said virtuous hemorrhage can happen in diabetes, acute loss, corneal opacity with blocking because of the blood in the posterior aspect. Central retinal vein occlusion will have blood and thunder, so you will see something in the fundus. Hard exudates is not really a thing. It's like it happens in a lot of conditions like diabetes, but you would still see red reflex. In this one, it's like combines all the elements together. Corneal opacity, so no red reflex. This one, you would still have it. Edema, also, you would still have it. This one is both, right? Also, edema and exudate, you will see in the fundus the yellow spots. So the non-proliferative diabetic retinopathy is nothing specific. You would still see the exudates and macular edema. Okay, so here no details mean it's blocked by all the blood. 3-month-old baby presents with persistent tearing of right eye. The mother massages here, okay, and then mucopurulent discharge is expressed. What is the most likely diagnosis? If you massage there, the duct, right, and then the discharge comes out, then that means the problem with this persistent tearing is the blockage of that duct. So the massaging actually helps drain it. So that means that the problem is in obstruction of the nasolacrimal duct. Okay? Young college student was studying hard for exams until she felt a foreign body sensation. You stain her eyes with fluorescence. If you see dendritic pattern on fluorescence like this with the bulb and the leaf-like thing, it is immediately either one of the two. Here it is herpes simplex virus because of the terminal dendritic branch. It can also be, sorry, herpes zoster, but that one is in immunosuppressed elderly with the skin rash, right? And yeah, that this is herpes simplex from this choice. What can be diminished in this condition? If I give you choices, corneal opacity, corneal sensation, foreign body, whatever. What is decreased here, because the corneal is invaded, corneal sensation is diminished. Okay, remember that. Corneal sense, so they cannot feel it as much, and they will feel a foreign body sensation, but diminished corneal sense. Which of the following is painful red eye condition? This is easy, I think. Hopefully. Scleritis is painful. Pterygium is benign growth, non-painful, not painful. Entropion is eyelid being inwards. It's not painful, it's just irritating. This is red eye, okay? It causes red, painful eye. Open angle glaucoma takes over time. It's painless, silent condition. Thank you, and this is the feedback. Hopefully it helped. And inshallah, best of luck with everything. If you have any questions, please feel free to reach out to me anytime. And thank you.